again, and today we're going to be talking about hospice and hospice issues. So today I have Diana and Tina here, and they're with Kindred Hospice, so I'm going to let them introduce themselves a little bit. So Diana.
Hi, my name is Diana, and I work with Kindred. I'm the DOO, which is the director of the program, and I'm here to answer questions about hospice and just be here to answer questions.
And I am Tina Miller. I am the hospice care consultant for the South Office.
So, and just tell them a little bit, you're a nurse too by trade.
Yes, I am a nurse. I'm an RN by trade. I've been doing hospice for over at least 16 years, and plus I've been in hospice longer than that in another position.
And Tina, what is your role with the hospice?
My role is to go out and support, advocate, and of course develop business with not just physicians, skilled nursing facilities, clinics, auxiliary, just anyone that might benefit from the gift of hospice.
So today we just wanted to kind of get some more information out there. I think a lot of times hospice comes up in conversations when you're dealing with patients, and at the time it comes up, I sometimes think people feel pressured or like they don't really understand what's going on, and a lot of things are happening at once. So just wanted to bring some clarity to the subject, talk about it, put some information out there just so everybody has some information that they can be thinking about and use this as a resource that they can turn to if they have any questions about it. So why don't y'all tell me, Diana, why don't you go first and kind of tell us what is sort of the broad picture of hospice? What is it about?
Hospice is about taking the patient home on a program where the patient is has a terminal illness. Usually the terminal illness is diagnosed by the physician. They usually have a prognosis of 6 months or less to live, although patients come at different times of their stage in the terminal illness. But what we provide is we provide a nurse to make a visit in the home. We provide home health aid to help with bathing. We have a chaplain that can help with the spiritual support, and we have the psychosocial team, a social worker that can help with other things that are needed at the time of death, because patients do have a progression where they are terminal, and we help educate them and help them understand what's going on with the disease, as well as how to take care of the patient in the home. A lot of times, simple things like turning a patient in the bed, or providing DME equipment for like a hospital bed, or learning how to use the oxygen machine. There are all these things that are necessary in order to keep the patient comfortable at home. So we provide that education, that training, and that support that the family needs so that they can take care of their loved one in a home where they're surrounded by loved ones, and they can be a family instead of in another environment where family may not be they may not be there for them. And in the home you have your comfortable place with your loved ones. Your friends can visit, even your pets. You know, we have a lot of families that have their pets, and so that's real important.
So I think one of the big things is sometimes it gets uncomfortable for people to talk about death and dying, and that's something that you guys deal with every day, all day long. And so one of the big things about hospice is, at a time, if you have a family member or a loved one that has what Diana was saying is a terminal diagnosis, or they have the estimation that they will probably be passing within the next 6 months, then their physician can see them and certify and say, if we leave this patient to the natural disease course, so we aren't intervening or doing heroic measures on the patient, there is a possibility that this patient could probably pass within that 6 month time period. Doesn't mean that they have to pass within that 6 month time period, but they could pass during that time. There has to be a reasonable expectation that that could happen. So hospice was originally created as an option for patients who were declining, who were deteriorating, whether it was from cancer, whether it was from dementia, coronary artery disease, heart failure, whatever it was. If they were the end stages of their life, some patients said, you know, I really don't want to spend my time in the hospital. I really don't want to take more medications. I really want to focus on the quality of my life and not so much the quantity. And so hospice came along as an option, an alternative to traditional wouldn't say necessarily traditional medicine, but as an alternative option for patients to say, you know what, I want to be kept, and we use the word comfortable a lot of times, so I don't want to feel a lot of pain, and I want my dying experience to be as comfortable as it possibly can be. And so hospice came along as an option for those residents who were seeking something along those lines. So Tina, when you're talking to a family who's considering hospice, what do you tell them, or kind of defining?
So oftentimes we begin the conversation with understanding their own understanding of where they are, not just in the disease process, but understanding what their goals of care, what that looks like for each of them. As Dr. Gibbons mentioned, we want this experience not only to be unique to their journey, but we also want to make sure that we are meeting their needs in terms of whether it's physical, emotional, spiritual, that holistic approach to be able to just be there and be that extra set of hands and eyes that have the privilege of journeying with them. The conversation goes in so many different ways depending on each of the different scenarios. If they're in a long-term care facility, if they're in the home setting, even when they are in the hospital, ready to receive a lot more additional care and support than what we would provide in a typical home setting. One of the many things that we have found that families have, for lack of a better term, come to terms of understanding is really accepting hospice in general, in terms of just understanding, okay, this is where we are and we're ready to receive this type of comfort care.
So I think one of my two big things for hospice is we have to be able to control pain. That's a huge focus for hospice, is controlling pain. And we have to be able to make it as good, I don't know if that's the right word, of a dying experience or death process as we possibly can. And so Diana talked a little bit about the support services, and I think those are underestimated a lot of times. I know a lot of people will even say they aren't religious, but in those kind of last days during that active dying process, I've seen a lot of residents suddenly want a chaplain or want somebody that can come. And if you haven't been established with a church community, there's not just somebody ready to show up at your house at a moment's notice. And I think that's one of the nice things with hospice is it gives them the social support to help the family dealing with the grief. It gives them the chaplain services. And one thing I don't think a lot of people know that maybe you can touch on, Diana, is the aftercare. Like even after the resident passes, does hospice just like stop the moment they pass, or does it continue?
No, the program continues with the caregiver that was responsible for their loved one. We have a bereavement chaplain that does he does like phone calling. He does actually visit the family if they need counseling in the home. But that service is provided for a year after the patient has expired. So we have a person that's designated specifically to help you through the grieving process. I mean, there will be material sent to you in the home. There'll be conversations on the phone. If a visit is needed, he'll go to the home and help with counseling. We definitely provide a lot of services through that program so that the person that is grieving is not alone. And that's really important to us because they've been through so much with the person that they loved. Now, what do? So we have a person that definitely helps that, and it's a chaplain, a bereavement chaplain.
So one of the things, Tina, when families are talking to you, do you think a lot of people think if I bring hospice on that they believe they're going to get a nurse every day and they're going to have an aide every day? I mean, I want to be clear about what services we provide and how frequently we provide them. So do you want to?
One of the biggest misconceptions about hospice is they tend to believe that maybe this is a 24-hour, 7-day type support system. we do have comprehensive care plans that are designed specifically for each of the disease processes that we're treating, in addition to being able to identify some of the maybe perhaps challenges that they're having, understanding, maybe doing some education. We do try to tailor that a lot to the needs of the patients, their families, where they are in terms of understanding. So one of the first things that we do when we do our initial visit with them is talk a little bit about what that's going to look like. As their needs increase, so will the visits. But we also want them to have a life outside of just caregiving. If they want to have some quality one-on-one time with families, and it's the holidays, it's a birthday, and they really want to have some intimate family one-on-one time, of course we honor and respect that and allow them to have that opportunity to have that, you know, that family unit to be able to celebrate, say their last goodbyes, exchange I love yous, whatever it may take for them to feel that they are getting what they need from us. After we talk a little bit about what not just what that care is going to look like, but also what they can expect from us. We are available 24 hours a day, 7 days a week, and there are times that we have to do several visits within the day because there's been
Changing
condition. Maybe we're addressing pain. Maybe there has been some whatever it may be. We want to make sure that we're available and ready to respond to their needs and their calls.
Now I know years ago, so I'm dating myself now, but for a while there used to be something called crisis care, and it was pretty common that as someone was starting to really decline, generally in the last 5 days or so of their life here on earth, they would typically qualify for something called crisis care, and a nurse would be at the bedside or a CNA would be at the bedside that would be helping tend to the patient and take care of them. Hospice rules changed though, and they stopped that a couple years ago. How many years ago? 3 years? 4 years? Somewhere in there.
Absolutely.
Yeah, so it's not that there's not crisis care, there definitely is crisis care. However, the qualifications for qualifying for it are much different. So the only way when you're in the active dying process that you qualify to have someone attending to is if you have a need for that professional service to be there. For example, you have secretions that can't be cleared and no one else in the house can be trained to help with that, or something along those lines. So they're a lot more stringent than I think they were several years ago of what that model looks like. That being said, the hospice model is not one where, especially patients, I think we take a lot of extra care with patients that don't have family members because we don't want to see people passing alone or by themselves. So why don't y'all talk about kind of experiences you've seen where you've kind of taken extra measures to make sure that somebody was there?
If I may, I'd like to share a specific case that comes immediately to mind. We had an 101-year-old lovely little lady that unfortunately was blind, and family was not as involved as we would want them to be. So there was an increase, not just support from our clinicians, the registered nurse that was coming in and making several adjustments to keep her as comfortable and as pain-free as possible, but our social worker, our chaplain, we had our volunteer team. It was a combination of efforts that really kept this patient to honor her wishes to stay in the comfort of home as long as possible. I think that case immediately stands out, not just from the standpoint of being able to honor, as I mentioned, honor her wishes, but to see her sitting in her little home and recite the rosary and have the comfort of home. I think it just has been meaningful in my experience.
So what would you all say, each of you give me kind of your favorite hospice story?
Well, I'm trying to think. My favorite hospice story is actually a woman that I took care of. She had a disease called with respiratory, and she lived out in the country. She was a country girl at heart, and her husband were this the nicest people you could ever know, and they treated you just like you were one of them. But the thing I remember about her experience in dying is that at that moment I had moved to another position, but she asked for me to go back to see her before she left this earth. So when I went to go see her, I touched her hand and she squeezed it, and she knew I was there, and that meant a lot to me as a nurse, as a case manager. I had her for a couple of years, and at that moment I knew that I had made a difference in her life, that all the treatments that we did at home, all the things that she did, she had went on a cruise and she had fallen and she had to have certain braces in her hand, and we went through that and helping her keep her respiratory condition under control, because she had exacerbations because of that. I mean, that to me just I felt like I made a difference in that, and to me that was a moment for me. So that was my story.
For me,
And I'm sticking to it.
Yes.
For me, I had the pleasure of witnessing two veterans. They were actually rooming together, both colonels, both honorary. A lot of similarities and a lot of pull at your heartstring moments between the two gentlemen. But unfortunately, when one took a turn for the worst and we recognized that he was imminent, we did share with his roommate, and he immediately wanted to be part of the final salute that we provide our veterans. To see them be so comfortable with one another, they shared a room, a lot of intimate moments, not in that sense, but needless to say, they shared a lot of great moments together. But to see them, to see his roommate stand for the final salute, just sent chills up and the entire staff. It was very heartwarming. It reminded us all, this is what we do, this is what this is about, and it just shows that just the human spirit, the ability for one another, two strangers that became family and then allowed us to become an extension of their care, was just grand for me.
That's awesome. So let's see, tell me about one of your worst experiences.
I'll go first. So I went out to the country, and I was visiting with a potential family. And to be mindful and respectful, I always kept saying your loved one, just because she was the soon-to-be ex-wife, but very involved and very active in the care. And until I said that one last, your loved one, she quickly clarified and said, now listen, that son of a, I'm here because of my children, but he's not my loved one, and I'm doing this to make sure that he gets the best care that he deserves for the sake of my children. But that was a lesson learned for me. Terms of endearment and things
You're like, you're loved or not so loved one.
It's either Mr. So-and-so or Mrs. So-and-so, because outside of that, not acceptable.
Okay, but my hospice story beats your hospice story.
Oh, let's see.
Okay, so I was asked to go see a patient at their home, which was an apartment building, and it's in a subsidized housing, let's call it that. Yeah, apartment complex, and there's one way in and one way out. And this apartment complex, when you drive in, like you're passing cars on blocks and stuff, and there's windows like all blown out, but there's people everywhere, and it's a weekday, and I'm like, does nobody here work? Apparently nobody there really worked. So I pull into the parking spot, and I get out, and I'm getting my white coat and my stethoscope out of the trunk, so it's clear that I'm something medical. They don't necessarily know I'm a physician, but they know it's something medical. So a gentleman and his ladies, yes, I said ladies, come over, and he kind of introduces himself and stuff. And so turns out he's a pimp. Yeah. So he starts showing me and telling me stories about where he got knifed in his side and showing me the gunshot.
All proud. Like, this is,
yeah, like I survived this. And I'm like, oh, that's so interesting, because like I don't want to die, right? So I'm like, oh yeah, interesting. So he's asking me where I'm going. I'm like, oh, I can't tell you where I'm going. That's private patient information. So but it's great meeting you guys. You know, I need to move on. I need to go do some work. So I'm leaving you. He's like, well, are you sure you don't want to join us? Like, you could be one of my girls. And I'm like,
I'm honored, bud.
I'm like, honored. I'm going to try the doctor thing for a little bit. See how it works out.
See if it works out for me.
See if it works out. And then we'll try the other one. And then the pastor was supposed to meet me, and the pastor was late. And so I get to the apartment that I'm supposed to be going to, and I knock on the door, and literally a cloud of marijuana like comes at me, and there's like drug paraphernalia everywhere. So the wife of the resident is there, and I say, I can't come in with any of that there, so I need you to shut the door, and I need everything to disappear that's illegal. And then open the door back up, and then I'll come and see the patient. So she shuts the door, and then I get on the phone and I call the marketer that you all know, that I won't name, but she knows who she is. And I chew on her for sending me to this place without any backup or anything. So, but I didn't die, and that was the great part of that story. And I came back.
But you have a backup plan if this falls through.
If it falls, I don't know if it's still there though. It's been a couple years. I've aged. I don't know. Might not be the same opportunities. I may be downgraded now, so don't know. But my car still had its wheels on it, so that was like a big plus too. So I did pay him $10 to watch my car though.
Oh, there you go.
Because I was like, I need to be able to drive out of here when I come back. So, what else can we talk about hospice? I think one of the big things is expectations of families of what's going to happen. And one of the big things I always hear a lot of times has to do with morphine. And I think there's a lot of perceptions in the public that if you get morphine, then that means one of two things. One, either they think, oh, you're going to kill my loved one, or Mr. or Mrs. or Miss or Mr. They're scared to take it for the pain issues that they have, and I don't think they understand about that. So one, either they're scared to take it, or two, they're requesting it like early on because a little too often. So kind of talk about that from the nursing perspective that you've seen with hospice with that, and how you educate families on appropriately using the morphine.
That's a very good question. We do use morphine to help our patients be more comfortable. A lot of times our patients, morphine is good definitely for shortness of breath. It's also very good for
cancer pain.
Cancer pain, and it's also a medication that is used definitely to help the patient when they can't swallow anymore, because there is medication. Morphine comes in a droplet form, and if you can't swallow and you have a patient that's in pain and needs some kind of pain management, the drops that you can put it's just like, if you know what a cc is, it could be less than that, it could be a quarter of that. Just put it under their tongue, and it helps the pain management, and it helps the shortness of breath. And a lot of people say that, oh, my mom's going to get addicted, but really morphine is a very good medication that really the body can take it, and it goes in the system pretty quickly. I would say that it's once you take the medication, that it's going to be out of your system in a couple of hours. So a lot of people say that, no, it's going to be in my system, it's going to be, but it's not, and it really works. When morphine is used correctly, it helps the patient feel more comfortable. They can have more quality time to be with their loved one, and it helps with the shortness of breath. I mean, I always tell my families, I mean, you don't want to have somebody in shortness of breath. It's not a very good feeling. The morphine definitely helps with that. So using it properly with the physician's orders, we teach the family how to give it appropriately, and make sure that the patient stays comfortable. So
Well, and I think it's a myth that people say, I mean, you can definitely overdose someone on morphine and have them pass. That's not the goal with hospice, though. The goal is to actually control the pain with the minimal amount of morphine that we can give the patient, but to keep them as pain-free as we possibly can, and to really help those who are having a lot of respiratory distress, help them with that issue, but not overdose them. And so that is a misconception that people think if I start on morphine, then I'm going to pass right away. We have patients that have lived years on morphine and have built up, levels where they have needed increased morphine, but at the point where you're in a terminal illness state and you're being certified that you have 6 months or less to live, we aren't worried about addiction at that point. We're worried about pain control at that point and ease of breathing, because it's just not very comfortable to feel like you're struggling to breathe. So also sometimes at the end of life, people will get that, they'll call it a death gurgle sometimes, but when their lungs start filling up with a little bit of fluid, you'll hear them, or you'll hear the rattling as the fluids, they just aren't able to swallow really well. And some people will suction them. I'm not a big fan of all the suctioning because it tears up the back of the throat and causes a lot of issues. But the morphine actually helps them relax a little bit too, so that they aren't struggling so much and feeling like they're having that drowning feeling. And so used appropriately, and that's what I want to emphasize, is that in hospice, that's what we're trying to do, is use it appropriately. So just wanted to kind of point that out about morphine. There are several other medications we use to help patients relax. A lot of times patients, when they're actively dying, or even before, if they have a lot of respiratory issues, they tend to get a lot of anxiety. We also give medications for that to help them relax a little bit, help their breathing ease from that standpoint too. Tell us a little bit about how the social workers work. Do they talk to the patients or counsel with them, or how do they help them?
A lot of times our social workers, they do an initial evaluation visit, which means that they'll be seeing the patient within the first 5 days. Preferably, we usually have them either on the first day or the second day. And what they provide is a lot of counseling. A lot of families have questions about funeral homes. What are my options?
Wait, how do you say that?
Funeral homes.
Funeral. That's definitely staying in.
And they have questions about the do not resuscitate orders. They definitely have questions like, what does that mean? What can I do? This is what my loved one wanted. They have a lot of questions. And what the social worker does is has a lot of education in providing what it is that they need at the time. I mean, people have questions like even, what do I do with my mom's estate? Where do I go to get, more information about the Social Security benefits? I mean, they provide that information. They can tell you what to do and where to go to get that information. Because a lot of times when you're in that state where you're having your loved one is passing away, you have these questions, and you're at the point where I need that assistance. I need that counseling. I need that person that I can talk to and help me with the finances, with whatever needs to happen so that I can take care of my loved ones. So the social worker is very, very helpful. We recommend always that the family is open to them, so that way they can introduce themselves and see exactly what the family needs. But usually the main questions is talking about the funeral home and the DNR, with the do not resuscitate
We need like
order.
subtitles, funeral home. Like,
So anyway, but they are very helpful. They have loads of resources to help with families, and where to look for stuff. So they're very, very helpful in planning whatever it is that the family needs. And we have a lot of experienced social workers. I mean, they do a great job.
On the business development side of the house, our social workers are vital in terms of not just helping us with placement, that oftentimes is a really challenging, not just from the hospital to a skilled nursing facility, assisted living, personal care home, but even when they are at home and they recognize that they can't do this type of care in the comfort of home, and they have to maximize resources. They have also helped a lot with last wishes. I think that has, if they want to connect with a loved one from Mexico that they haven't had an opportunity to have closure with, those are the moments that really are meaningful to some
Right,
of
they
these
define their
families.
experience.
Yes.
And I think one of the last things I wanted to bring up is talking about placement and stuff. So a lot of times we see with patients with dementia especially, we often see that the caregivers, so the person providing the care, a lot of times it's a spouse, that they tend to pass before the dementia patient does, because they get so run down trying to stay up and constantly keep up and look out for that person. So one of the things that I think is really neat that a lot of people probably don't know about hospice is that hospice recognizes that caregivers do get burnout at times. And so there is something called respite, which is a program where the hospice will coordinate to have the patient put in a nursing home environment for a period of time, 5 days at a time, so that the caregiver can have rest. Either they can go on vacation, or they can just have the days to just not feel like they're completely responsible. They can still go see the patient in the nursing home, or like I said, they could leave and do something else for those 5 days, knowing that their loved one is being cared for, so they have an opportunity to go do errands or things they can't normally do. How often does that respite, how often can that benefit be used?
It is a coordinated effort, and we typically like to talk with our families that it is a benefit covered 100% through Medicare, because it is a benefit that needs coordination of care because of the different facilities. We do it as often as once a month, typically for 5 days. If there is a need for more, then again we'll coordinate that with our clinical team to make sure that we're giving them what they need.
Yeah. So I think those are things sometimes people don't know about, the different resources, and that's a really great benefit, I think, that gives people that opportunity. I think also there is sometimes some fear of people having their loved one pass at the house, that they feel, and I know people don't like to talk about monetary things, but I've been asked before, if they pass here, will it decrease the value of the house? Will there be other issues with it? Or families saying, I just don't want them to pass here because I don't want that memory of them passing to be here. And some people are comforted by it, some people are not. But that's where the social workers can help arrange too. If somebody's in that decline, that we could make arrangements to put them into a nursing home type environment.
Or with our interdisciplinary team approach, we can schedule our different clinicians. If we have to stagger some visits, have the nurse, the social worker, the chaplain, a combination of teams team clinicians to be able to be at bedside for the comfort of the family, for just again to be another set of hands and eyes at home in the event that they start to feel a bit intimidated with the dying process.
Yep. So anybody have any closing things they want to say here, or anything? What's the last thing you want to leave everybody with hospice?
I know we wanted to stay briefly, talk about, we have the spiritual support, the chaplain. I feel like that's a pretty important part that sometimes gets missed. I know you touched on it briefly, but I feel like it would be a real good advantage for the family to be open to them. And they're very respectful of whatever religion, or you don't have a religion. They're very respectful of that, and they're very well trained to work with the families, because sometimes you just need that person to reminisce, to talk about the past and kind of get some things out. And even the patient that's on the program, they need that support. And it may not be that they want to talk to a chaplain, but the chaplain can be that person that is there for them, so they can unwind, and sometimes reminiscing and talking about things that they might have wanted to do. The chaplain can very much help them go through that process at the end stage of the emotional and spiritual part of dying, and they bring that together and help the family come together with that, because sometimes it is a reality that starts to creep up, and families get really scared, and the patient gets scared too. So having that person that's trained very well in spiritual support can be there for them.
And I think also too, a lot of our chaplains actually have other skills. So a lot of times they'll sing hymns with the patient, or they play harmonica, or they do things that incorporate other tactile senses and things for the residents, which I think is really, really neat. So, and just so you all know, the cases are reviewed every week. So different patients are reviewed each week at a meeting where we have all the disciplines together. So everybody's reviewing what's going on with the patient. Are we controlling the pain? Is the patient still doing well? Are there any issues we need to address? So those are frequently addressed by the whole team as a whole, and the team is then communicating through those visits that happen throughout the week for the resident. So it is a very coordinated system that covers all the interdisciplinary team approach to everything. So in closing, do y'all have anything you want to leave everybody with?
I'm hoping that the takeaway from this conversation is that in the end, it's not what you say or how you say it that matters. It's the ministry of presence. It's that hand you're holding. It's that opportunity to be at bedside with your loved one, with your family, with your extended care. So we're hoping that this information was useful, and call me if you have a patient.
Yeah, yeah. Call Tina. She's available.
Yes.
Cut.
Thank you guys.
Thank
Bye.
you. Bye.